Hello, everyone, and welcome to today's specialty webinar, Safe Treatment of IBD Patients with Thiopurines, TPMT, Genotyping and Phenotyping. Our two presenters today are Dr. Ann Moyer, Assistant Professor of Laboratory Medicine and Pathology, and co-director for the Personalized Genomics Laboratory at Mayo Clinic in Rochester, Minnesota. Our second presenter will be Dr. Piero Rinaldo, who is Professor of Laboratory Medicine and Pathology and co-director for the Biochemical Genetics Laboratory at Mayo Clinic in Rochester, Minnesota. Just a couple of reminders before we begin. There will be a question and answer session at the end of the program. You can submit questions online via the chat function, or following the presentation, the phone lines can be unmuted to ask questions. Today's program is being recorded and will be posted to our website in a few weeks. And now, let me turn the phone over to Dr. Moyer.
Thank you for the introduction. So today our objectives will be to differentiate between TPMT genotyping and phenotyping tests for thiopurine toxicity and to determine when to order, to interpret genotyping and phenotyping test results with specific attention to Mayo Clinic's new 3-analyte TPMT phenotype test, to recognize NUDT15 as an additional contributor to thiopurine metabolism, and to gain confidence in avoiding patient toxicity when ordering thiopurines as treatment for inflammatory bowel disease. I have no disclosures. Thiopurines are medications used for a variety of indications, including inflammatory bowel disease, acute leukemias, autoimmune disorders, and in the setting of transplantation to avoid rejection. These medications mimic the structure of purine bases that are incorporated into DNA and RNA. Thiopurines lead to cytotoxicity and immunosuppression. Let's walk through the thiopurine metabolism pathway with this simplified diagram. When a patient takes azathioprine, shown here as AZA, it is first rapidly converted into 6-mercaptopurine, shown here as 6-MP. Next, 6-mercaptopurine is metabolized by competing pathways, with xanthine oxidase converting 6-mercaptopurine into the inactive 6-thiouric acid, or the enzyme thiopurine methyltransferase, or TPMT, can convert into 6-methylmercaptopurine into the inactive 6-methylmercaptopurine. Alternatively, in a multi-step pathway initiated by hypoxanthine guanine phosphoribosyl transferase, 6-mercaptopurine can be converted into the active 6-thioguanine nucleotides, shown here as TDGTP and TGTP, which can ultimately be incorporated into DNA, resulting in cytotoxicity and immunosuppression. Genetic variation within the gene encoding TPMT can result in some individuals having reduced or absent TPMT enzyme activity. When this occurs, an excessive amount of 6-MP can be converted into the active 6-thioguanine nucleotides, which can result in serious life-threatening adverse events. However, this testing is available to identify patients with reduced or absent TPMT activity and is recommended prior to initiation of therapy by the U.S. Food and Drug Administration. While TPMT testing is very helpful in identifying patients at risk for thiopurine-related toxicities, not all patients who develop toxicity have variants in TPMT. Therefore, TPMT testing cannot identify all patients at risk of toxicity. Now, I did mention that this was a simplified pathway diagram, so let's uncover a little more of the complexity of this pathway. So NUDX15, or Nudix hydrolase 15, or NUDT15, also known as MUT-T homolog 2, is responsible for the dephosphorylation of the active thioguanine nucleotides. NUDT15 dephosphorylates the active triphosphate forms to the inactive monophosphate forms. Therefore, if NUDT15 is not fully functional, the active 6-thioguanine triphosphate forms may be present at higher concentrations and lead to increased toxicity. Like TPMT, NUDT15 is also genetically polymorphic. Recent literature now suggests that NUDT15 testing prior to initiation of thiopurine therapy may also be helpful in guiding treatment selection and dosing to avoid toxicity. So to recap, when a patient is starting on thiopurine medication, TPMT testing is recommended by the U.S. Food and Drug Administration. This can be accomplished by use of either an enzyme activity assay that you'll hear about towards the end of the presentation today, or genetic testing, which we'll talk about first. Use of either or both of these tests is recommended to identify individuals at increased risk of developing thiopurine toxicity. NUDT15 has emerged in recent literature as an additional significant contributor to thiopurine metabolism. Therefore, we now recommend testing for NUDT15 in addition to TPMT. And based on the results of TPMT and NUDT15 testing, the starting dose of thiopurine medication is determined, or in some patients, perhaps a different medication is selected. So now that we've covered some of the background, I'll be talking today about genetic testing for both TPMT and NUDT15 variants. Then Dr. Rinaldo will discuss details of Mayo Clinic's TPMT3 enzyme activity assay, and we'll wrap up with time for questions at the end. So let's discuss the details of the combined TPMT NUDT15 genotyping test available through Mayo Clinic. Genetic variants in both TPMT and NUDT15 affect the activity of the enzyme that is produced. Based on genetic variants identified through testing, enzyme activity of both TPMT and NUDT15 can be predicted. For example, if a patient has no variants in either TPMT or in NUDT15, he or she would be expected to have normal enzyme activity and be considered a normal metabolizer. The term normal metabolizer is relatively new. If you were reviewing an older report, you may see the same phenotype referred to as extensive metabolizer. If a patient has a variant that leads to reduced enzyme activity on one allele in either TPMT or in NUDT15, he or she would likely be referred to as an intermediate metabolizer for that enzyme. It's shown in the middle diagram here. Finally, if a patient had a variant that led to reduced enzyme activity on both alleles of TPMT or NUDT15, he or she would be referred to as a poor metabolizer for that enzyme. And although here I've shown just 3 categories of enzyme activity, it's very important to note that in reality there's a spectrum of activity, with some patients demonstrating enzyme activity in between categories. And this is in part because of multiple variants have been identified within the TPMT and the NUDT15 genes, and not all variants inactivate the enzyme to the same degree. So next, let's further explore some of the variants within the TPMT and NUDT15 genes. Most clinically available TPMT genetic tests use a genotyping-based strategy, detecting specific variants known to lead to decreased activity. These assays can only identify the specific variants that the test is set up to detect. Our laboratory uses TaqMan-based real-time PCR assays to detect single nucleotide polymorphisms within both the TPMT and the NUDT15 genes. The diagram on this slide represents the TPMT gene, with the coding exons represented by blue boxes, the non-coding exons as white boxes, and the line through the middle represents the introns and the 5' and 3' flanking regions. Each position queried in our assay is identified by an arrow. As you can see, we are able to detect 7 single nucleotide polymorphisms, or SNPs, with our assay, while most laboratories typically only detect 3 to 4 SNPs. The genotyping results are then used to categorize patients into groups by predicted TPMT activity phenotype, including normal metabolizer, intermediate metabolizer, and poor metabolizer based on the alleles detected. This slide shows a similar diagram, but now for the NUDT15 gene. As you can see on this diagram, our laboratory is able to detect 3 single nucleotide polymorphisms with our assay. Similar to the TPMT portion of the assay, the genotyping results are then used to categorize patients into groups by predicted NUDT15 activity phenotype, including normal metabolizer, intermediate metabolizer, and poor metabolizer, based on the alleles detected. When the TP-NUV test is performed, both TPMT and NUDT15 are genotyped. A genotype and a phenotype for each gene is reported, and an interpretive comment ties the results together, providing a recommendation. At this point, TPMT testing is widely accepted, so at this point questions are arising as to who needs to be tested for NUDT prior to thiopurine-based therapy. Is it only important in patients from specific populations? Well, this table shows the frequency of the SNPs included in our test and is broken down by population. NUDT15 variants are on the left in the gray boxes, while TPMT variants are on the right in the white boxes for comparison. As you can see, the TPMT *3 variants that are included in the assays offered by most laboratories and are included in the current clinical guidelines have a frequency that ranges from less than 1% to about 5%, depending on the population, with an overall frequency in the 2 to 4% range. The NUDT15 *3 allele has a frequency over 10% in the East Asian population, around 6% in the Latino and South Asian populations, and an overall frequency in the 2 to 3% range. In addition, the *4 and *5 variants are also present at a frequency of greater than 1% in several populations. So therefore, depending on the population studied, NUDT15 variants may actually be more important for your patient than TPMT variants. In the United States, our ancestry is not always fully known. Therefore, it would be very difficult to know whether a patient should be tested for TPMT, NUDT15, or both based on only ancestry, so we offer a combined test that includes both genes. As I mentioned a moment ago, one limitation of genotyping-based assays, in contrast to sequencing-based assays, is that they are only able to identify the variants that they are designed to detect. Most clinically available TPMT and NUDT15 genetic assays are genotyping-based. This is in part because genotyping-based assays are less expensive than sequencing assays and because they have a much quicker turnaround time, which is definitely an important feature when your patient is waiting to initiate therapy. There's variability among the clinically available tests in both the number of variants that the test can detect, as well as which variants the test can detect. This is especially important to consider because some patients will receive a result of *1, which is considered to be a normal metabolizer, and the patient would be expected to not require or to not be at higher risk of toxicity when treated with thiopurine medications. The *1 genotype is not assigned after detecting a particular variant, but rather *1 is assigned in the absence of variants. Therefore, it is important to consider which variants are included in the test, both when selecting a test and when interpreting the test results. So let's look at an example using TPMT, although the same concept would apply to NUDT15 tests as well. In this example, there are two assays for TPMT. The one on the top of the screen detects variants at 3 positions, denoted by the orange arrows. The one on the bottom of the screen detects 7 variants, also denoted by orange arrows. The gene is represented by the blue line, with the orange arrows positioned approximately where they would be located within the gene. The yellow symbol indicates that this example patient is positive for a genetic variant at this position. There is an orange arrow present at this position in both assays, so this variant can be detected by both assays. And so in this case, the result for the patient in the top assay would be *2, and the result for the patient on the bottom assay would also be *2. So now let's look at a different example. So in that case, basically both patients would be resulting in intermediate activity and be the same result. But in this new example, you can see that the position is in a location that is not denoted by an orange arrow in the top assay, so therefore this assay would not be able to detect this patient's genetic variant. On the other hand, the more comprehensive assay on the bottom, there is an orange arrow that's located in the position where the yellow variant is, and therefore this test would detect this variant. So in this example, one of the patient's alleles has the *5 variant that decreases enzyme activity. If his or her other allele does not have a variant, then this patient's genotype would be star 1, star 5, and result in intermediate activity. In the assay that did not detect this variant, on the top, the patient would incorrectly be assigned the star 1 genotype and be classified as a normal metabolizer. This could place the patient at risk for thiopurine toxicity because the provider would likely use a standard dose of therapy rather than reducing the dose. In contrast, in the assay on the bottom, the allele was detected and the patient was correctly assigned the star 1, star 5 genotype and an intermediate activity, and therefore probably would have received a reduced dose. So please note that although I just showed you an example of a patient who would have been incorrectly assigned the star 1 genotype, in most cases, patients who are reportedly star 1 normal metabolizers truly do not have a variant. However, in cases where the genotype does not fit well with the clinical phenotype, or if few SNPs are included in the test, this may be something to consider. In addition, when selecting a test, it is important to consider which variants can and cannot be detected because not all tests for a given gene are equivalent. So far, we've learned where TPMT and NUDT15 fit into the thiopurine pathway. We've covered the basics of how genotyping tests work, and discussed the frequency of TPMT and NUDT15 variants. The next big question is, how do you put this information together to decide on a treatment strategy for your patient? Guidelines are available for the use of TPMT results, but at this time, guidelines are not yet available for NUDT15, nor for combining the two results. However, there are now a number of studies in the literature where genotyping has been performed on both TPMT and NUDT15. In these cases, the number of alleles that result in decreased activity are counted and are called a risk score. Let's look at an example. This is an example from a study published in the Journal of Clinical Oncology that shows the impact of the genetic risk score combining TPMT and NUDT15 genotyping results on the dose intensity of mercaptopurine that was tolerated. This study was performed in two separate cohorts. The one on the left included 657 children with acute lymphoblastic leukemia enrolled in the Children's Oncology Group clinical trial AALL03N1, while the one on the right included 371 children with ALL treated on the St. Jude Children's Research Hospital total therapy protocol. In both cases, the planned dose of mercaptopurine was 75 milligrams per square meter per day. The dose intensity shown on the y-axis was indicates the clinician prescribed dose relative to the protocol dose. And along the x-axis is the genetic risk score, which is the part that I'd really like you to focus on. The patients who had no variants in either TPMT or NUDT15 had a risk score of 0. Those who were heterozygous for either gene had a risk score of 1. And those who were either homozygous for one of the genes or had heterozygous variants for both of the genes had a risk score of 2. And no patients were identified with a risk score of 3 or 4 in this cohort. And as you can see, the mercaptopurine dose intensity decreases with increasing score. In addition to this study, in this same study actually, the authors also found that among children who were homozygous for NUDT15 variants or who were heterozygous for both NUDT and TPMT variants, so those who had a genetic risk score of 2, in that case 100% of them required a greater than or equal to 50% mercaptopurine dose reduction compared with only 7.7% of the other children. So although our example was from a published research study, how does this actually work clinically? In the reports for TP-NUV, which is Mayo Clinic's combined TPMT and NUDT15 genotyping test, the genotype and phenotype results for both genes are independently reported. Then an interpretation that incorporates both NUDT15 and TPMT is provided based on the concept of the genetic risk score. So let's take a look at an example of what that might look like. So this is an example of a normal report and suggests that our patient, who is in this example, would have a normal risk of toxicity when treated with thiopurines. As you can see in the results section, in the middle of the screen, the TPMT genotype is star 1, and the patient has a normal TPMT metabolizer phenotype. The same is true for NUDT15 in that the patient's genotype is also star 1, and this patient is a normal metabolizer for NUDT15 substrates. So together, this patient's genetic risk score would have been 0. And the interpretation at the bottom describes that there was a normal risk of toxicity when treated with thiopurines. And so basically, this patient would receive a standard dose. In contrast, you can see that in this example, this patient wasn't quite as lucky. She has a rare TPMT genotype of star 2, which means that she is predicted to be a poor metabolizer of TPMT substrates. In addition, she has a star 1, star 3 NUDT15 genotype, which means she is predicted to be an intermediate metabolizer of NUDT15 substrates. So she has a total of 3 deficiency alleles, 2 for TPMT and 1 for NUDT15, so her genetic risk score would have been 3. The interpretation at the bottom indicates that indeed she is at higher toxicity risk when treated with thiopurines. The provider who receives this report doesn't have to worry about how to combine TPMT and NUDT15 genotypes and phenotypes for this test, as it is taken care of in the interpretation. So as I mentioned earlier, TPMT can be tested using a genetic test like what we've been talking about so far, or an enzyme activity test, which is what Dr. Rinaldo will be talking about in a minute. So if this TPNUV genotyping test combines TPMT and NUDT15, why might someone even want to use the activity assay, and how would that work? Well, I mentioned earlier that TPMT and NUDT15 activity is a spectrum from poor to normal metabolism. So for TPMT, that spectrum can actually extend further, in that some individuals have increased or hyperactive activity. This is rare, but it can be detected by the enzyme activity assay and not by the genotyping assay. In addition, patients who have very rare variants in TPMT would not be detected by the genotyping assay because if you remember back to the slide with the orange arrows, there wouldn't be an orange arrow in some of those rare positions. On the other hand, the TPMT activity assay only includes TPMT and does not detect individuals with NUDT15 variants. Therefore, at this point, the optimal approach is really to utilize both of these tests together. In that scenario, the TPMT component will typically be concordant between the 2 different assays. So you could look at the TPMT section from the TPNUV report and TPMT3's report and verify that indeed they were concordant. After verifying that the results for TPMT are concordant between the activity assay and the genotyping test, one could then use the recommendation from the TPNUV test that combines interpretation for TPMT and NUDT15. In the rare cases where TPMT results are not concordant, we would encourage you to call the laboratory and we would be happy to assist you with interpreting the results. So in summary, TPMT and NUDT15 both contribute to thiopurine metabolism, and individual variation in either gene can contribute to increased risk of toxicity when patients are treated with thiopurines. TPMT and NUDT15 testing is available to detect individual variation and is recommended prior to the initiation of thiopurine therapy. TPMT is available as either an enzyme activity assay or as a genetic test. NUDT15, on the other hand, is currently only available as a genetic test. At Mayo Clinic, the genetic test includes both TPMT and NUDT15 together in one test. If a patient has a variant in either or both genes, a dose reduction or potentially an alternate medication is recommended. The combined TPNUV test result includes a combined interpretation, and it is important to note that although these tests are very helpful in predicting which patients are at increased risk of toxicity so that their medication dosing can be adjusted or an alternate medication can be selected, careful clinical monitoring for signs of toxicity remains essential to ensure patient safety. Now I'll turn this webinar over to my colleague, Dr. Rinaldo, to walk you through the TPMT3 enzyme activity assay.
Thank you, Anne. Good morning. The second portion of today's webinar describes the development and validation of an improved biochemical assay for the evaluation of TPMT activity. By the end of his presentation, my goal is to have been able to demonstrate why we consider it a model of precision medicine by phenotyping. I have no disclosures to make. This slide shows an outline of my presentation that will include a retrospective evaluation of the old assay, technical details about the new assay, and an overview of our approach to post-analytical interpretation using CLEAR, a multivariate pattern recognition software. As already mentioned by Dr. Moyer, thiopurine drugs are prescribed for the treatment of severe conditions, including lymphoblastic leukemia and inflammatory bowel disease. The in vivo inactivation of these drugs is mediated by the enzyme thiopurine methyltransferase, abbreviated from now on as TPMT. As described almost 40 years ago in a seminal paper by Dr. Winchenbaum here at Mayo Clinic, erythrocyte TPMT activity follows a pattern of monogenic inheritance, where approximately 10% of the general population has genetically reduced enzyme activity due to heterozygosity for a pathogenic variant, and 0.3% is deficient for carrying two of them. Both groups are consequently at risk of drug toxicity. Characterization of TPMT activity prior to administering thiopurine drugs, as you have already heard, is one of the first successful examples of applied pharmacogenomics, and it is now the standard of care as recommended by the FDA. Dr. John O'Brien in our department set up a TPMT assay in 1999, and it was based on the analysis of a product of a single substrate, 6-mercaptopurine. The activity of the enzyme was expressed as unit per milliliter of red blood cells lysate. Keeping in mind the calculation of this unit could be done in slightly different ways, leading sometimes to systematic differences in results. This plot shows a representation in ascending order of the more than 136,000 patient samples tested over the following 16 years using the assay until the assay was discontinued. This table shows the values corresponding to the 0.3 percentile, the 10th percentile, the median, and at the opposite end, a high peripheral percentile. It can be assumed from this pattern of distribution that a value greater than 40 should be considered abnormally elevated. If we focus back on the low values and we zoom the plot in that part of the data distribution, it seems that the 10th percentile falls in an apparently seamless continuum of values, while the activity corresponding to the 0.3 percentile is very close to the inflection point where values start to plunge. Over the years, clinical decision points settle to what is shown here, notably including a so-called low normal range that extended significantly into the reference range well above the 10th percentile, which is 11.4. These cutoff values were selected based on the worst-case scenario observed in a relatively small number of patients with both phenotype and genotype results, including a few subjects who were heterozygous by genotype but also had a TPMT residual enzyme activity well above the 10th percentile. This pie chart shows how the 136,000 cases were reported. The proportion of deficient cases was almost triple of what it should have been. Heterozygotes were about half of what was expected, but most importantly, a real large proportion of cases were reported as low normal or indeterminate. Accepting the criteria of monogenic distribution and leaving unchanged the proportion of deficient and heterozygote cases, the proportion of indeterminate cases should have been much lower than almost 20%. This modified slide shows a direct comparison between what happened in this group and perhaps what should have been. Given or taken some variability, it appears the low normal activity was overcalled in no less than 20,000 patients. The actual interpretation that was provided in those cases is shown here, inclusive of language clearly suggestive of low activity. On the other hand, a relatively small proportion, but nevertheless clinically important portion of cases was given a normal report, despite evidence of unusually high activity that could have been instead suggestive of hypermetabolizer status. Shown here is a comparison of heterozygote status decision point among 4 laboratories performing comparable one-substrate TPMT assays. The background is a representation of moving percentiles that will be discussed later. While one lab appears to be substantially different, our lab and 2 others were very close, indicating that the overreaching decision point was not an issue unique to our practice. So we decided to obsolete the old assay and work on a comprehensive update using tandem mass spectrometry with specific emphasis on pre-analytical automation and many additional changes toward the goal of achieving better reproducibility and consistency, which were the greatest challenges of the old assay. In addition, a decision was made to explore the possibility to expand the number of substrates used to measure TPMT activity, and therefore allowing the creation and interpretation of a more complex profile. 2 additional substrates, 6-methyl-mercaptopurine riboside and 6-methyl-thioguanine riboside, were added. As a result of introducing a competitive assay, the MPP reference range dropped significantly. It could not be easily compared to the old assay. On the other hand, the total activity calculated as the sum of the 3 products was somewhat comparable to the old reference range, especially at the critical decision point around the 10 percentile value. The clinical utility using 3 substrates is to create a more elaborate profile of markers and 6 calculated ratios. They are better suited to recognize a biochemical fingerprint that is indeed unique to each genotype, deficient, heterozygote, hyperactive. The 3 products, the sum of their activities shown here as total, and the calculated ratios are presented in this plot as percentiles calculated as multiple of a reference median. A display of each marker plotted against itself in comparison to the respective range of peripheral percentiles confirm the expected pattern of overlap between controls and heterozygote patients. However, a very different picture becomes apparent when MPP is plotted against each of the other markers, showing a better separation between contiguous groups. So, while a single analyte plot shows substantial overlap, bidimensional plots of a primary marker reveal unique patterns of differentiation, which are even more pronounced by comparing every possible combination of markers, suggesting the existence of complex patterns indicative of less overlap between controls and heterozygotes. That is great, of course, but how these complex patterns could be integrated and interpreted? This is where clear tools become relevant to deliver enhanced clinical utility by improving specificity, by setting a goal of substantial reduction of unnecessary low normal results. CLEAR is an acronym for Collaborative Laboratory Integrated Report, a multivariate pattern recognition software and interactive web tool that was initially developed to support Region 4 STORC, a federally funded collaborative project for laboratory quality improvement of newborn screening by tandem mass spectrometry. R4S has evolved into a worldwide collaborative project being used in 68 countries to test more than 27 million newborns over the last 6 years. In particular, the post-analytical interpretive tools have been used to generate 368 million scores, equivalent to a volume exceeding 150,000 per day. Since 2012, CLEAR is supported entirely by institutional funding, has been approved as an official product of the Mayo Clinic. CLEAR has been a consistent driver of innovation. In 2012, we first demonstrated how to interpret complex metabolic profiles without using static and mostly arbitrary analyte cutoff values. In 2014, we showed how this software could have prevented as many as 90% of newborn screening false positive outcomes experienced by the California Department of Public Health. In 2015, our main collaborator, Dr. Lars Morkred from Oslo University, laid the statistical foundation for a novel approach to the definition of reference intervals. This year, we have shown how CLEAR could be used for novel biomarker discovery. The link to the online publication is also shown. And for the first time, we have introduced the concept of precision newborn screening, defined as a sustained achievement of near zero false positive rate in large-scale population screening. This publication will appear online in just 3 days, on November 9th. Briefly, what CLEAR does can be summarized in 4 major components. First, we have introduced the CLEAR enhanced the clinical utility of the individual markers by automatically creating all possible permutations or ratios, as shown in a previous slide. Second, CLEAR replaces conventional cutoff values with a definition of a condition-specific degree of overlap between reference and disease range. Third, CLEAR replaces conventional reference ranges with continuous covariate adjusted moving percentiles. Finally, CLEAR replaces traditional sequential algorithms with post-analytical interpretive tools working as parallel algorithms, meaning that all relevant markers are assessed simultaneously. Post-analytical tools are defined by their potential clinical utility. For example, one condition tools are meant to replace the conventional concept of a normal-abnormal binary interpretation with an objective assessment of likelihood of disease, which is expressed as a percentile rank in comparison to known affected cases. For example, this is a software-generated report of a CLEAR tool for the biochemical diagnosis of heterozygous status. There are 4 sections in this report. The first one shows, from top to bottom, the case score, 117 in this patient, the percentile rank of the score in comparison to all heterozygous cases uploaded to the database, and the current count of such cases. CLEAR generates 3 scores, each calculated in comparison to cases from a single site, in this case the Rochester location of Mayo Clinic, cases from an aggregator perspective, which could be customized to be an institution, a state, a country, or even a continent, and on the left side for the entire application. The values in these reports are identical because only our lab has contributed data so far. The score interpretation guidelines correspond to the first, 10th, and 25th percentile of the scores for confirmed heterozygous cases, but these can be modified also as desired, and any test can be customized as well. The rationale to display 3 scores will be explained in more detail in the next slide. Before going there, I would like to underscore one more time the concept of percentile rank as an objective and quantitative measure of likelihood of disease. The score range plot is a graphical representation of all scores, each represented by a band. In this example, the choice of aggregator is the United States. The utility of comparing separate score ranges is demonstrated by this example, showing scores for a condition detected by newborn screening. The Swedish program can compare the score of a patient to increasingly larger number of cases, 12 of their own, 100 from all over Europe, and 1,000 worldwide. The first section of the report is the plot by condition, a visual comparison between reference and disease ranges, shown as multiple of a reference median, and the results of each marker in the case under evaluation, shown as red diamonds. This plot is useful to detect discrepancies in the pattern that could be caused by an artifactually high or low value of a single marker, potentially leading incorrectly to the assignment of an informative score. The final section, usually shown on the back side of a report if printed on a single sheet of paper, summarizes how each marker contributed to the final score. We believe this section is needed to dispel any concern a provider may have that the CLEAR score interpretation are generated by a black box-like hidden algorithm. An educational presentation that describes all details of the score calculation process, including the use of weighted correction factor, has been posted on the MML website since 2013. The 3 tools for the recognition of each clinically relevant status or TPMT activity are shown here. Clearly, the counts of available cases for deficient and hyperactive status are still relatively low, and these tools should be considered still under development until more cases have been added. The next type of CLEAR functionality is the all condition tools, the instrument available to check simultaneously and generate a score for the 3 tools shown in the previous slide. The all condition tool consists of 2 sections, the percentile rank plot and the actual score plot. Shown here is a case informative for hyperactive status. all of the color-coded diamonds are direct links to the one condition tools. A TPMT deficient case is expected to generate two informative scores. The milder condition heterozygote showing a higher percentile rank. The situation triggers the display of the icon linking to the dual scatter plot, the clear tool for the differential diagnosis between two conditions with similar and overlapping biochemical phenotype. By clicking the icon, the dual scatter plot is displayed. In this plot, the relationship to reference ranges becomes irrelevant, as a comparison now takes place between two disease ranges. The dual scatter plot is actually the combination of two identical tools. One that targets any non-overlapping result to increase the score for the first condition and decrease the score for the second one, and another that operates exactly in the opposite way. Another characteristic of the dual scatter plot is a different way to express the calculated scores. Instead of absolute values, both axes use a process of min-max normalization that keeps the score within 0 and 100 while preserving the relative distance between values. The output of a dual scatter plot is a visual separation of the combined scores in 4 quadrants. The lower right quadrant includes the cluster of cases with the first condition, both with a high score in one tool and a low score with the other. The upper left quadrant includes the scores of cases with the second condition. A score located in the upper right quadrant is interpreted to be an indeterminate result, meaning that both conditions are still possible. Finally, a score in the left bottom quadrant excludes both conditions. When used to investigate an unknown case, the coordinates of the combined scores of a particular case are shown as a red diamond. A dual scatter plot is actually needed for better definition of hyperactive cases in comparison to normal cases. To generate this plot, all controls were added to the database as individual cases, and a single condition tool was created. But the far most relevant scatter plot is the one designated around the critical need to segregate TPMT heterozygotes from controls. While the indeterminate quadrant appears empty based on confirmed cases, this is a process that determines the reporting of a case as indeterminate when found through prospective testing of clinical samples. Finally, the tool runner is a high-throughput functionality capable of deploying and integrating all the tools already described. Whilst the tool runner is chosen from the menu of post-analytical tools, a batch of approximately 100 samples is processed in less than 5 seconds. It is now time to evaluate how the new assay has performed today in comparison to the old assay. As a reminder, the outcome of the old assay is shown again, with an overall proportion of normal low results greater than 25%, or 1 in 4, when should have been close to 1 in 10. While the number of cases is significantly smaller, approximately 6,000, the relative distribution of outcomes has been as follows. 0.2% was reported as deficient, 10.8% as heterozygote, only 2% as indeterminate, 87% as normal, and 0.1% as hyperactive. In other words, less deficient, more heterozygote, and most importantly, many less indeterminate results. Collectively, 11.7% of cases was reported as abnormal low, which is a significant reduction in comparison to the old assay, exactly 13% less. In the clear workflow for clinical application, special attention is given to what we can describe as the loop, a process of ongoing data mining to support constantly evolving and improving clinical validation. Every case with concordant genotype-phenotype resolution is promptly added to the database. For the hyperactive cases, in the absence of genotyping information, a case is deemed as true positive when both a one-condition tool and the dual scatter plot are informative. Our hypothesis is that interpretation based on what we know today could perhaps be more accurate to what was done when the available data set was progressively smaller. Again, This is a pie chart of outcome with the new assays as they were reported. This time compared to how they would be reported now, today. The differences are small, but nevertheless significant. Today, 0.3% will be reported as deficient, 11.1% as heterozygote, only 0.3% as indeterminate, 88.2% as normal, and still 0.1 as hyperactive. In other words, a few more deficient, matching closely the expectation by monogenic inheritance, more heterozygote, and most importantly, an almost 80% reduction of indeterminate outcomes. Collectively, 11% of cases will be reported as abnormal low, a further 10% reduction toward the predicted ideal state of findings supporting the clinical utility of constantly evolving and improving clinical validation. And there is more that we can do in CLEAR. First and foremost, the adjustment of results for one or more covariates. This plot is called the marker versus covariate plot, where the values of a chosen marker, here MPP from the new assay, are shown. All cases and controls are shown individually with different colors. As to be expected, considering this is the activity of an enzyme in erythrocyte, the moving median does not show much variation, especially between 10 and 95 years of age. However, age-adjusted values, expressed as z-scores, greatly expand the range of low values, a feature that could be particularly relevant to optimizing the separation between deficient and heterozygote cases, and perhaps also between heterozygote cases and controls. Another function incorporated in CLEAR is a Gowans plot, a statistical concept introduced 30 years ago to compare reference data by category, in this case sex. By plotting cumulative data over a continuous covariate, usually age, the median of the male and female populations are flanked by a band spanning plus minus 1/4 of a standard deviation. The resulting plot shows if there is a statistically significant separation that would require the selection of separate reference intervals. The display of this plot requires large amount of data, so it was not only possible to apply to the old assay. While there seems to be no statistically significant difference, it could be argued that females are consistently lower than males, and factoring sex could contribute to improving the separation between conditions. This is a marker versus covariate plot adjusted for both age and sex, and indeed, it appears to expand the range of low values. So one more comparison can be made between the unadjusted outcome discussed previously and a reanalysis of the same data after adjustment for age and sex. While predictably, things do not change much, it could be argued that a 0.2% or 10 cases decline of abnormal low cases could be clinically relevant, also when considering the threefold increase of hyperactive cases. Finally, another contiguous covariate that could be factored in is the hematocrit. The value adding a second continuous covariate could be found once sufficient data becomes available in the opportunity of creating tridimensional reference ranges, like the example shown here. This plot shows the median, orange plane, plus minus 1 and 2 standard deviation of the amino acid phenylalanine in dry blood spots, adjusted simultaneously for two continuous covariates, age of collection and birth weight. The count of data points exceed 1.2 million. To summarize this presentation, a multi-analyte biochemical test combined with post-analytical interpretation by multivariate pattern recognition software is capable of delivering an accurate phenotype characterization of patients before treatment with thiopurine drugs. We do call it precision medicine by phenotype. If interested, again, please see our paper in press in Genetics in Medicine. As I mentioned earlier, the advanced online publication is scheduled for November 9th. Consistency of genotype-phenotype results could be regarded as a gold standard of TPMT testing, and indeed, integrated counter-reporting of any combination of tests performed by our laboratory and Dr. Moya's laboratory, extracted from our laboratory information system, will be launched in early 2018 after the enterprise-wide implementation of a common electronic health record has been completed. It is also important to understand the discrepancy of genotype and phenotype results are possible and will occur. When found, they could be an indication of a high complexity situation. My personal bias is that the presence of a particular variant allele in a patient showing normal enzyme activity against 3 different substrates should not necessarily override the phenotype. And finally, it is of the utmost importance that we conclude this webinar with a notion that genotyping, particularly the detection of NUDT15 alleles, and phenotyping, recognition of hypermetabolizer, do address unique and important aspects of clinical utility and individualized patient care that the other tests just cannot recognize. I would like to acknowledge all the colleagues who have made this work possible, beginning with the staff of the Biochemical Genetics Laboratory, particularly Coleman Purgeon, the colleagues of the Personalized Genomic Laboratory, all the people involved with the coding, testing, and implementation of the CLIR software, and finally, the support I received in the last 10 years from the T. Dennis Sanford Professorship Fund. We will be happy to answer any question you may have at this time. Otherwise, Dr. Moyer and I are easily reachable via email at your best convenience. We thank you for your attention.
Dr. Rinaldo, Dr. Moyer, you have both presented an astonishing amount of work. Thank you very much for what you do. At this time, we'd be happy to take any questions you may have. If you would like to ask a question through the phone line, just press *7 to unmute your phone. And once you have finished asking your question, please press *6 to remute your phone. You can also submit questions via the chat function on the Level 3 Communications web application. So we will sit tight here for a couple of minutes to let people digest what you have heard. We see that people are still muted. I wonder, Dr. Rinaldo or Dr. Moyer, you get a lot of questions that come in from people using Mayo Clinic's tests around the country and around the world. Is there an example or two you can share with us that may be helpful to our listeners and in the use of these tests that you've been describing?
Well, I guess I can go first with that one. So for our TPNUV test, we just launched it on October 23rd, I believe. And so we started to get some of our first tests coming in. And previous to that, we had only been doing TPMT testing without NUDT15. And you see the allele frequencies and assume that that means that you should actually get patients that are positive for this, but you don't really know until you actually start getting those first test results in. And indeed, we've started to see patients that do have variants in NUDT15. And I haven't had the opportunity to talk with any of the clinicians yet to see how that's impacted the patient's care, but I would predict that that would be actually quite important for them. So I'm glad to see that indeed we are seeing patients with those variants that they definitely would have been missed before, and so I think this will really enhance their care, that they can get the correct dose of the medication.
Thank you, Dr. Moyer.
We do have one person with their hand raised. So Donald Waltz, I'm going to unmute you. And what's your question? Yes, how does the...
Hi, I also sent the question in, but how does the use of 3 different substrates overcome the problem with the quality of the cofactor, specifically ethyldenacylmethionine?
Can you elaborate on what that issue is, because I'm not aware of it?
Donald, are you there?
Yes, can you hear me now?
Yes.
The S-adenosylmethionine, when you purchase it, the quality is not usually guaranteed, and I think your lab has observed variation in the quality of S-adenosylmethionine.
I'll be happy to convey your question to the development tech, Mr. Turgeon, who will develop the assay, and I think I'll be able to track you down and give you a more specific answer. If you see, my email is still listed there. It's just my last name @mayo.edu. So if you want to send me, offline message, I will be happy to respond to that after I found out more information.
We want to thank everyone for your participation in the webinar today. If you do have additional questions, please indicate them on the Level 3 evaluation that displays when you disconnect from today's program. You may email them as well to mmleducation@mayo.edu, and please reference this webinar. As a reminder, this program was recorded. It will be archived and will be available on our website within a few weeks. Thank you once again for joining us today. Thank you, Dr. Ronaldo, Dr. Moyer, and everyone have a great afternoon.